Hello, everybody. Welcome to Conversations in Aesthetics. I'm your host, Dr. Gary Goldenberg, dermatologist from New York City. And today I have a great pleasure of welcoming one of my closest friends in dermatology, Dr. Joel Cohen, who is a dermatologist, a Mohs surgeon, a researcher, really a Renaissance man living in the wild of Denver, Colorado. Joel, thank you so much for being here and welcome to the show.
Thanks for the invite, buddy. I appreciate it.
You know, you and I have known each other for a long time, and we love talking cosmetics, and we've done a lot of work together, published some papers together, so I'm excited for us to have this conversation.
I'm still waiting for our ski trip together, buddy.
I know, we need to do that. One of these days we'll do those. You're too good of a skier for me. I don't think I can keep up with you, so we'll take that conversation off camera. Joel, I want to talk to you because I know you've been doing aesthetics for a long time, and you know, tell our audience your approach to a patient who walks in, you know, for quote unquote Botox, and you walk in and you do the aesthetic consult. What does that look like for you in your practice?
Many patients walk in just as you indicated, and they point to an area such as the upper lip, and they say, you know, hey, I'm here for a little bit of Botox or Dysport. And you look at their upper lip and they have significant etched lines. So first, I let them know that there are different treatment approaches for different areas, and when people don't have resting lines, but they're starting to form, maybe they're starting to get a little bleeding lipstick in the upper lip, that might be the time for neuromodulators like Dysport and Botox. If they have some lines, but they're not that many, and they're big enough that you can actually get the tip of a needle into or thread a needle through the area, then that might be appropriate for some filler. But when people have a lot of etched lines, numerous lines, and it looks like what we call peau d'orange or orange peel texture or the barcode, that is a time for resurfacing. And in my experience, that's not just fractional ablative resurfacing that you're going to see modest improvement with one session. That's a time to think about full field, heavy, full field resurfacing with erbium.
So am I gathering from what you just said that somebody comes in not knowing what they need, knowing that there's a problem area that they want to address? Do you really go through the entire scope of what's possible? Like, I always think of it from my practice when I do the cosmetic consult. I tell my patients, look, I'm going to be very honest with you with what I see. I give them a mirror and I kind of point out, you know, the pigmentation on the surface, the etched in wrinkles and lines, the dynamic wrinkles and lines, the loss of volume. And then we go through the list of things that we can do from the easiest to the most complicated. What does that look like for you in your practice? Give us sort of the inside scoop of the Joel Cohen cosmetic consult.
So I have a little 3-ring binder, and my staff is always trying to get me to switch to an iPad, and we're at that point where I feel like it's probably time to go because there's enough photos, and the organization of those photos needs that. But I think the 3-ring binder has really served me well. I have one picture, that one slide that actually shows those 3 examples. Somebody who has columns but not etched in lines, somebody who has some lines that we can approach with filler, and then somebody who's clearly very different, has a lot of imprinted lines in the skin that would benefit from resurfacing.
So I know in your practice, because people in Colorado are very outdoorsy and you're closer to the sun and there's a ton of sun damage. I mean, I was in Denver for my fellowship and had the pleasure of seeing patients there as a moonlighter, and I don't think I've ever seen as much sun damage as I did out west. So you really focus on the resurfacing part of it. You really think that's your go-to.
You know, first I'll agree with you that people who live here by and large enjoy over 300 days of sunshine. We do get 4, 5, 6% more UV penetration for every 1,000 feet. So if you're skiing up at 13,000 feet or you're hiking, you know, a 14er or something like that, you are getting a ton of sun exposure. So I have a lot of my patients who are buffs and make sure they're UPF buffs, especially after I resurface them. But sun protection is absolutely vital. And when we really pick the right tool for the job, it's hard to really think about the timing because we have sun exposure and significant sun exposure all year round. So some of my patients might be actually out in the sun more skiing than they are in the summertime. So we really do resurface patients all year round, and we really look to see what they look like and what their downtime can actually be.
And I know you brought some videos to show our audience, specifically on the resurfacing piece. So I'm looking forward to seeing those and talking through that. But what would you say is the most common complaint or concern that you address with your aesthetic patients? Is it sun damage? Is it volume loss? Is it shaping, sculpting? What is it, Joel?
It's definitely sun damage, and I think that many people don't realize the importance of using sunscreen with the right ingredients, reapplying sunscreen, wearing a wide brim hat, and really seeking the shade when they can. You know, a lot of times patients will go out for a business lunch, they'll be sitting outside and they'll say, yeah, it's just, an hour here. And all of a sudden, they have significant sun exposure, and it's tough. My wife and I went for a walk 2 weeks ago on a canal that's near our house, and I saw a patient who is a melasma patient. And every time she comes in, she tells me she wears a hat, she wears sunscreen, she wears sunglasses, and she's there walking her dog, and I start laughing when I was about 30 yards away from her because she had none of those things that were visible.
Yeah, I think we all have those experiences where we meet a patient somewhere and they're like, oh my God, I forgot my hat, I forgot my sunscreen, but usually I do, and you're like, yeah, sure. Just come back after your sun damage, goes away a little bit. So that's very interesting. We've had several guests from different regions of the country, and what amazes me is that some of the concerns that we address are somewhat regional. And I think where you are, definitely sun damage probably is one of the most common things that it sounds like you treat. So you've done the consult. What's the plan? How do you formulate a plan of action for each patient? Do you try to individualize it? Do you kind of have like a one-size-fits-all approach? What is that like in your practice, Joel?
For many of these patients, they need to address not just the etched lines and the significant sun damage, but they do need to think about some volume replacement as well. So I think it's appropriate to talk about a different sort of treatment plan for everybody based on what downtime they can do and really what they financially can afford. So a lot of times, we might start with a little bit of filler and place it in the marionette area, place it in some key structural points in the cheeks and just sort of reinflate those areas. And for some people that may be enough, and then they have to plan accordingly for the time to resurface. And I do use a lot of fractional ablative technology, especially with the new technology from Aclaro that allows us to do laser-enabled tissue coring, where we can actually vaporize larger holes in the skin, and that can contract the laxity. So doing fractional ablative technology treatments are really helpful, and that can be 5 to 7 days of time to reepithelialize, and then the heavy resurfacing can be 10 to 14 days to reepithelialize.
So, Joel, this is a debate that I know has been out in the literature and then between our colleagues, not only in derm but plastics. Somebody comes in for a new patient you see, and they say, you know what, I want to do some resurfacing. In my office, that would be CO2. In your office, it might be various devices. But they say, I also want to do some Botox and filler. Do you think it's okay to do it before you do the resurfacing? What's the time period that you would wait between doing, let's say, HA filler and botulinum toxin and then bring him back for resurfacing? Do you think it makes a difference?
That's a really important question. There's been some data that has come out over the past several years, even starting back by Gassner at the Mayo Clinic, that really talked about patients had lacerations in the forehead, and around the time of the laceration, within a day or two, they got neuromodulator in the forehead so that they contracted on the scar less. And that's something that I did in Mohs. A lot of times when you had a tight flap, you really just want to immobilize the area so there's less tension vectors on that. And then in my fellowship, Gene Carruthers was very interested and published on treating with Botox the lateral canthal area before resurfacing, so that when people are healing, they don't recapitulate the lines to the same extent in the very same spots. And then in 2007, Ada Almeida and Kadunk published in Dermatologic Surgery doing resurfacing, but they actually, with one quadrant, so the upper lip got neuromodulator on one side but not the other side, and they showed decreased mechanical activity and more improvement on that specific side. So now we know that that's much more complicated, and there's a lot of different cytokines and chemokines that are factors that downregulate some of the collagenase and gelatinase and some of the matrix metalloproteinases. But I think there's been an evolution, and I try to get these patients to come in really a week before, at least a couple days before, and then if not, then while they're reepithelializing, and I do check on them several times over the course of that week or 10 days, then we can go ahead and do those injections.
So what you're saying is that doing botulinum toxin, let's say a week before a heavy resurfacing laser is okay. Do you think that a heavy resurfacing laser is going to destroy filler that you're putting into, let's say, deep dermis subcutaneous tissue?
I don't. I think there's been a lot of good data at this point to suggest that the wavelength and the temperature and the focus of the heat and the wound healing response is not really affecting filler at all. However, there have been some studies looking at other energy-based devices, and I'll give the example of ultrasound. Ultrasound probably does affect the durability of filler because it's going down 3 to 4 millimeters. And some people feel when you use fractional radio frequency or different radio frequency devices, like the monopolar radio frequency devices, that you're going down deeper as well. You may affect that, and there's been studies looking at both sides of that. Jeff Kenkel's work showed that it doesn't, and Bob Weiss's work showed that it might.
So what you're saying is that you can do Botox fillers. In my practice, I always wait 2 weeks because I think that's how long it takes for patients to see the optimal result from those two treatment modalities. You wait 2 weeks, it's okay to do heavy resurfacing, but you wouldn't necessarily do all therapy or thermage in those areas because those products, those treatments do go down deep and may affect the durability of filler. And I completely agree with you. I think since you're just rattling off different references, maybe we'll put the references in the show notes for those who want to check and go back and read those articles. I think that might be very helpful. So why don't we jump into the videos, because I know you brought several, and let's show sort of how you prep your patients. So I know you have a video on dental blocks, and I'll also drop a reference. We actually published an article in Cutis on different blocks useful in dermatology, so you can look that up. But let's see the video that Joel, you were showing with doing a block before you do the heavy resurfacing. Talk us through this.
Let me preface this by saying that, as dermatologists, we become very familiar with infraorbital and mental blocks. And I think for a lot of things that we do, such as heavy resurfacing on the face itself, that will suffice. We do have things like Pronox, which is nitrous mixed with oxygen that can decrease anxiety, and it can actually decrease some discomfort. So I get patients with a loading dose of Pronox before I end up doing the infraorbital and the mental blocks. But I will say that when it comes to doing heavy resurfacing around the mouth, usually the infraorbital and the mental block are not enough to give you that ability to really tolerate this around the mouth. And as a dermatologist, we don't tend to bring anesthesiologists in the office. We tend to figure out ways that we can make patients comfortable. So the Pronox, and then doing the infraorbital and the mental block, and then I do what I call a sulcus block, where I now take plain lidocaine, so no epinephrine in this lidocaine, and I go into the sulcus of the mouth so that I can, and this is after the infraorbital, so they're really not feeling much, but that way they're not going to feel the vibration, the heat from that heavy erbium resurfacing. So we can play the video.
So I have a question for you, but for young Lou, let's run the video so that people can see Joel actually doing the lip block. But Joel, I have a question for you about Pronox, because I have it as well, and I think it's a great tool for some procedures. But I'm a little bit apprehensive using it since it has flowing oxygen while I'm doing a laser. What's your take on that?
So first, when I'm using Pronox, I have patients get a loading dose on board. So it's usually, 8 to 10 to 12 breaths. So, a guy who's almost 200 pounds like me, it may take a little longer. My wife is 5'2", and, she feels it after 5 or 6 breaths. So it's different for everybody, but you wait till that point where you literally feel like, you're pledging a fraternity. And then secondly, then you take it away and you start doing, the blocks and you keep them comfortable. And then before I do the sulcus block, I have them go back to another loading dose, because once I do the sulcus block, they're really not able to make a great oral competence. But for some people, that's it. That's the time that we use that. And for other people, they may feel from an anxiety perspective or from the noise or from the air evacuator perspective, they need to have additional Pronox. And I have no problem taking a pause in the procedure and having them do additional deep breaths into that. When it comes to actual resurfacing in that specific zone, I don't do that. I do know some people that do that. There's probably a little bit of trailing oxygen and nitrous in that area, but it's on demand. So I have no problem just taking a pause and let patients use this the way it was really designed. The Pronox was, designed for birthing units, and it was on demand for discomfort, and it works great for that.
So just to summarize for those for the listeners, you're okay having the Pronox device in your room while the laser's in there, but you're not firing the laser, so there's no spark while they're using Pronox, so there is no possibility of the whole thing blowing up.
Correct.
Is that right?
So while the patient has the tubing on their chest, there's actually no flow, right? Or the circulating nurse has the tubing, they're holding it, there's no flow. When the patients start breathing again, there's actually flow through the tubing.
Yeah, just make sure those knobs are all tight. Make sure there's no oxygen flowing, just free flowing. All right, let's go to the next video, because here you're showing the actual resurfacing of those vertical lines, which I think some people will still call smoker's lines, even though a lot of patients don't get them from smoking. So talk us through this, please. Tell us what laser you're using. I'm sorry.
Sure. So many patients have these deep barcode lines. And in this circumstance, I really think that you pick the right tool for the job. So if this patient is looking for major improvement with one session, it might be before a granddaughter's wedding or whatever it is, then I go to full field resurfacing. I tend to use this more for patients that are more fair complected, so type 1 through type 3 patients, and I can do heavy resurfacing. You can see she's very comfortable from that approach that I just went through, including the sulcus block. And then to differentiate erbium versus CO2, erbium has an endpoint. So even a country boy from Denver like me can recognize the endpoint of pinpoint bleeding here. Whereas CO2, it can be very subtle. In my fellowship, I did a lot of CO2 with great people like Jason Rivers, and honestly, it's a very subtle endpoint of that tissue contraction. And I talk to Susie Kilmer about this regularly. And Susie Kilmer and Vic Ross are two of the people out there that can really recognize that CO2 contraction. I feel more comfortable using erbium because I can see the pinpoint bleeding. I can see when I'm at that point in the dermal papillae where I'm like, okay, it's time to sort of back off. And then on the next video, I go after some of the individual lines. So I think it's helpful to have an endpoint, and that's why I use the plain lidocaine for the sulcus block, so I can actually see that endpoint very clearly.
So the plain lidocaine prevents there's no epinephrine, so they're going to bleed. You're looking for pinpoint bleeding. So just tell our audience exactly what device you're using here. It's okay to use brand names.
So sure. This is Cyton Joel, the TRL. And I've been using this device since 2008 for really heavy resurfacing. And I will say that, this has been a technique that's really been pioneered and taught to us by plastic surgeons. So Jay Burns has written an article in Plastic and Reconstructive Surgery about 20 years of using this type of erbium device. And he points out the physics here where we need to understand that erbium binds water more efficiently than CO2, 11 to 16 times more efficiently. And erbium has less of an overall thermal imprint. So if you're binding water more closely and you have less thermal imprint, then you actually affect the pigment very differently. So with erbium, if we stop at that endpoint, we don't tend to see that post-inflammatory pigment loss or that porcelain look that was common when CO2 full field resurfacing really came out in the 90s.
You know, it's so interesting. And again, it goes to show you not only regional differences, but difference between physicians. I've test driven both CO2 and erbium, several devices, and ended up with a CO2 laser because in my hands I feel like it's just better from what I like to do and my population of patients, because I think that pinpoint bleeding is not always something that people in New York City would be okay seeing, whereas maybe where you are, and I know you're not a country doctor, you're a well-versed professor of dermatology, so don't say those things about yourself because everybody knows who you are, Joel. It just goes to show you that there's differences in approach, and I think that's totally okay because we're probably getting to a similar result with different tools.
You know, I agree with you. I have CO2 in my office, so having the flexibility of different devices is really something that you can use. Some patients come in and they insist on CO2, and I want to be able to accommodate them. But I do agree. Having gone to medical school at Mount Sinai, I know the patient clientele that you're dealing with, and some people are just going to say, look, I work down on Wall Street. I'm really busy. I can do, a long weekend type downtime, but I can't do what you're describing is this heavy resurfacing. And I have a faculty appointment at University of California, Irvine. We see patients there who've spent their life on the beach and really aren't willing to really take it easy and not go surfing and spend that time on the beach post laser. So we really have to pick the tool for the patient that's going to give them the results they're looking for with the appropriate downtime, and really understand that for everybody it's a little bit different. And using a combination of these treatments, from neuromodulators to filler to resurfacing to some of the non-ablative lasers that you can use really all year round on any skin type.
Yeah, I agree. I mean, I love my patients, but I think convincing somebody to take 5 days off from their life in New York City is rather difficult. But they understand that it's necessary. But I agree, there are regional differences, and there are differences between physicians and what they like to do and what they're comfortable with. So let's roll the next video, because I think this is something that is newer. So why don't you talk through this fiber laser enabled tissue coring?
So the 2910 nanometer fiber laser is a laser by Claro called UltraClear, and they really have been first to market in a technology that allows the laser to vaporize larger holes in the skin. So the holes that the laser is now vaporizing, it's using something called Laser Coring Elite, which is 270 microns. So, and then there is a larger laser coring, which is about 360 microns. So for people in the secondary smile lines, along the jowls, people who have redundancy of the upper lid, and the lid is literally coming close to the lashes and that degree of dermatochalasis, I can go multi-pass over these areas with laser-enabled tissue coring and give them improvement. And it's usually a few treatment sessions. And on top of that, I do use the more traditional fractional ablative settings, or I can do full field settings as well. But being able to vaporize these larger holes can lead to some tissue contraction. And this is exciting to be able to see coring with the combination of laser at the same time. So when you're looking at, after one procedure, you're looking at the improvement. Patients aren't getting distracted by just looking at the laxity. They're actually looking at the improvement in lines and luminosity and pigment as well.
That's great. I want to go back just for something we touched on, because I think it's an important topic. It's the pain control or anesthesia. So you'll do the blocks, you'll give him some Pronox. Are you doing a topical also, or you're skipping the topical?
So in my practice, we've had a little bit of a shift recently. There is an oral medication called Jurnavix, which is something that doesn't allow the patient to propagate as much nerve conduction. And so I offer Jurnavix to patients, And so they would take that a couple hours before the procedure, usually on an emptier stomach, and then eat maybe 45 minutes or an hour later. Then they come in, and then we apply topical anesthetic to the area. So if we're doing the face, usually a 30% lidocaine. And then while they're being prepped, we get the Pronox set up, and then the patients, I'm discussing with the patient, I'm marking with the patient. I go over the areas where I need to do heavier resurfacing, usually around the mouth, into the secondary smile lines, and then attenuating the settings laterally in the cheek, and then marking the eyes. And then we have the patient lay back, and then we start to have them use the Pronox, and then go forward with the infraorbital and the mental, and then the sulcus block.
And how long do those blocks take to become effective? How long are you waiting?
I mean, the blocks are very quick. For me to do all that, the marking and the blocks and those types of explanations, it's about 10 minutes. And I like to do that myself, for sure the marking myself and for sure the blocks myself. But a lot of times my staff will get the tubing set up, and patients can do Pronox if they're a little anxious before I come in the room for the procedure as well.
That's great. Very helpful. I think that's one of the things that a lot of our colleagues are concerned with is the anesthesia and pain control during these heavy resurfacing procedures. One more question about the resurfacing. So I know there's been a lot of data when using things like PRP, exosomes, stem cells in conjunction with resurfacing to try to decrease the downtime. Now, my personal view in this is the downtime and the inflammation is what's going to drive the collagen production. So I tend not to do it during the procedure. I tend to have them come in maybe a week or two later for mesotherapy with PRP or some topical application of exosomes. What is your view on this, Joel?
So first, when we're doing heavy resurfacing and I see that endpoint and I know I'm deep and they have pinpoint bleeding, I know that they're going to have a significant improvement from that treatment. So if patients want to heal more quickly, I have no problem doing PRP, and I started doing PRP in my practice in September of 2016. It was right around the time when you and I wrote an article together, and you were getting very into the whole PRP world. I've seen you lecture at Fall Clinical and do some really important work on what we apply to patients topically and what we can do for patients with PRP injections. So I have no problem using that to try to facilitate healing. And then I've been really impressed with Ariessence, which is pure platelet-derived growth factor. And at least in my experience, I would say that the majority of patients that use that may heal about 20% quicker. And I tend to show them a sequence of photos of what to expect when I do fractional ablative resurfacing, for instance, with laser coring using the ultra clear, or I use full field resurfacing and show them what they're going to look like. It's important that the full field resurfacing, people need to understand that they're going to have yellow, and yellow is fibrin, and fibrin is not necessarily infection, and everybody's trained to think yellow, infection, do I need antibiotics? And there was a really important consensus that I co-authored. Arisa Ortiz spearheaded the entire endeavor looking at ablative resurfacing. It was published in Lasers in Surgery and Medicine last fall, and some of the things that we expect, which is post-inflammatory erythema for really up to 4 months, and then some of the things that we don't expect and hope we don't see, like post-inflammatory hyperpigmentation, and then it goes through, we pre-medicate patients with valcyclovir and antivirals, and most people don't pre-medicate people with antibiotics. So I like to see patients back every couple days while they're reepithelializing and make sure that they look okay and make sure they're comfortable with the whole process. And seeing those patients, I think some of these patients do heal a little bit more quickly with Ariessence or with PRP. But if you think about Ariessence, it's packed with huge amounts of pure platelet-derived growth factor, higher amounts than actually you can get in PRP.
That's great. Very helpful. Joel, I'm going to put you in the hot seat. Are you ready?
I'm ready.
This is a portion of the podcast where I ask you some quick questions, and we're gonna, we can talk through them, but I'd like kind of like your first gut reaction. Okay, you ready? Let's do this. So the first one is your favorite botulinum toxin.
Neuromodulators are something that
it's not quick, Joe. Joel, I want a quick answer.
I did my fellowship with the Carruthers. I learned neuromodulators with them, and in my practice, I use more Dysport than anything else at this point because I use more of the Restylane portfolio of fillers, and I use a fair amount of Sculptra, so I'm going to go with Dysport.
So Dysport is your favorite botulinum toxin. First from the show. Everyone else has said Botox so far. So, you like being different. I like that about you. So that's good. Favorite filler?
My favorite filler is really Restylane Contour. I feel like I can have versatility with that, and now that it's approved for the temples, really it's something that's helpful as far as multiple uses in my practice.
So if you can only have one filler, each company has like a portfolio of 10, right? I'm exaggerating, but something like that. If you could only have one for the rest of your career, if you were told you can only use this one product, that's it. It's Contour?
It would be Contour for multiple uses, but I do a lot of lip augmentation, and I really love Kiss.
So it's really Kiss for you. All right, I got you. Favorite laser?
Favorite laser? Honestly, the 1927 thulium laser is the most versatile laser. You can use it on any skin type. You can use it for patients that have melasma, very light, low heat, and you can use it for people who have a lot of roughness and even precancer type lesions. And now the work that's been done from Harvard, Matt Avram's group that really looked at doing sequential treatments with non-ablative fractional, including 1927 or 1550, and reducing the incidence of non-melanoma skin cancer, I think is important work. So I would go with 1927 thulium.
Okay. What is the device that you use most often day in and day out in your practice?
I would say laser-enabled tissue coring is something that's become very helpful in my practice. So I approach patients with acne scars, people who have chickenpox scars like I do, and then blending that with resurfacing and being able to give patients really nice improvement, including at the area of jowling and secondary smile line. I mean, it's exciting to be able to give patients those types of results. They just have to be okay with some bleeding and some wound healing.
Okay, just two more, Joel. Okay, you ready?
Yes.
Your favorite procedure of all time?
Heavy resurfacing. Just resurface them, and the photos should be visible, that it should be transformative. Patients should come in and say, look, I don't even need to go to the standardized camera system. I am happy with the results. That's one of the things that I dread the most is when somebody comes in, they've done one little procedure and they're like, let's go to the Vizia system and let's see after one little pico, what we've done. Like I don't want to do that. I want to actually give patients dramatic results.
Go big or go home. I love it. I love it. And what is your favorite condition to treat in your office?
I think it's significant etched lines, because we can make them so much better. Patients with acne scars, it's challenging. We can't make them, go away. And the expectation and the hope for all these patients is that their acne scars are going to go away. And we can do, significant things. But when it comes to, a patient with type 2 skin who has severe photodamage, a lot of pigment, a lot of roughness, a lot of lines, a lot of elastosis, if we just go with heavy, heavy full field resurfacing, one treatment, tough downtime, about 10 to 14 days to reepithelialize, and about 3 to 4 months of post-inflammatory erythema, we can be something that's transforming their lives.
That's great. And we'll make sure we drop the before and after pictures from some of your procedures in the podcast as well, so people can, while they're listening, can look at those pictures and see the difference that you're giving patients. So that's really great, Joel. Just one more question before we wrap up. If you put on your thinking cap about the future, we've kind of evolved from Botox being like the starter drug, if you wish, the thing that people always dip their toes with. Where do you think aesthetic medicine dermatology is heading? If we're having this conversation, let's say in 10 years, what are we talking about then?
I think aesthetic medicine is really heading the way other fields have looked at wellness and longevity, and we're going to see people really enter that curve of wellness much quicker, start thinking about the importance of sun protection, hopefully at a younger age, and then really get on board with using skincare with the right ingredients and thinking about how things actually work. And now there's more data looking at individual ingredients with skincare. I'll take THD, tetrahexyldecyl ascorbate, is something that has been found to be more stable, more effective, and more penetrating in some studies. So when people say I use a vitamin C, we can look and pin down specifically what type of vitamin C. And then really the concept of priming the system for senescent cells, working on ATP production and making sure the skin is able to respond to things.
I love that. I think that's really the future. It's preventative and looking forward as opposed to just trying to fix things that already happened. So I love that. I love that approach, Joel.
Well,
Joel, thank you.
Kids. I've got kids.
I know.
And, that sun protection part is so tough. And every time my kids send me pictures from somewhere, I'm like, "Where's the hat?" And I'm like, and they say, "Dad, I took it off for the photo." And I'm like, "Come on! Every single photo you took it off, even the extemporaneous ones where somebody took from a distance. I'm not that stupid."
We have a very easy rule with our kids. If they get a sunburn, the rest of the vacation they wear a long sleeve rash guard, pants, a big hat, and they sit under the umbrella. So there's a disincentive to getting sun.
Even to an indoor dinner, right?
That's exactly right. Joel, thank you so much for being a wonderful guest and such a great friend to me. I really appreciate you, as you know. And thank you, everybody, for listening to another episode of Conversations in Aesthetics. As you know, you can find all of our episodes on dermsquare.com. And until next time, thank you so much.